This episode was recorded in Q1 2026. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
Actually an overlap between ADHD and impulsivity and issues with executive dysfunction can lead to increased snacking and maybe binge eating disorder. On the other hand, somebody who's on stimulants like methylphenidate or Tyvence, which is this dexamphetamine, that those stimulants can reduce appetite. So there's a risk of somebody using those stimulants to keep their appetite low. So it can go either direction.
Hello and welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm continuing my conversation with Dr. Aoife O'Sullivan, one of the authors of the Irish College of GPs Eating Disorder GPU, which was published in December 2025.
So my name is Aoife O'Sullivan. I'm a GP. I work in Cork. I work in the Student Health Centre in UCC. So a part of my role there is working as a regular working GP, but also doing a lot of mental health consults due to the age of the population I deal with, which are mostly 18 through to 30-year-olds. I also work with the Irish College of GPs as the clinical lead in mental health.
This is the second half of my conversation with Aoife, so please go back and listen to part 1 first if you haven't had a chance yet. You'll find it in the show feed. In today's episode, Aoife discusses aspects of care including an approach to focused examination, when to organise additional investigations including bloods, DEXA and ECG, when to refer to the emergency department versus specialised eating disorder clinics, an overview of medication options and resources for patients and their families. As usual, I'll include chapter markers and links in the show notes. Aoife began today by discussing the use of the SCOFF screening tool.
So yeah, if you have somebody coming in that maybe ticks some of those boxes that we've just been talked about, and you're wondering, could this be disordered eating or even an eating disorder, the validated screening tool is called the SCOFF screening. It's in the GPU. It's 5-point screening questionnaire, and it is useful to look at. I suppose it differentiates between, again, people who've maybe just are their weight is off for various other reasons versus those whose lost weight specifically are restricting due to an eating disorder.
As you said, 5 questions, and if you answer yes to 2 or more, that's a positive screen, and then more work, I suppose, would be warranted. It's
only a screening tool, absolutely. Exactly. It just kind of helps you, maybe point you in the direction that this is something we need to explore.
And as you said, on page 3 of the GP update, there's a really nice 1-page outline of the kinds of areas that you could potentially explore with your patient during the history taking. Is there anything from that you'd like to highlight, or before we move on to the examination part?
I suppose from my point of view, I found it handy actually to put, and this is obviously very individual depending on your practice software, to put some of the points from that history just into either an investigation or a consultation drop down, just to remind you, because I find that to ask these questions, because sometimes these patients are extremely good at diverting you and chatting and you suddenly realize 25 minutes have gone by and we've not actually, asked about, say, laxatives or vomiting, because they're so good at diverting you. So I think it is really useful to tick through those points as best you can. And for GPs, we often need to know details. I remember hearing about, for example, rapid weight change from the psychiatrists and kind of saying, what is that? What does RAP mean? On a practical day-to-day level, what does RAP, can you define it for me? So that would be defined as, approximately 1 kilo or more a week, or 20% of body weight lost within 6 months. So having those little definitions is useful, and that little sort of aid memoir to ask maybe about inducing vomiting, about laxative use, about compulsive exercising, mood changes, and maybe just remembering to ask about comorbid illness, for example, diabetes, because people can control their weight using or restricting their insulin, which is extremely dangerous, or about neurodiversity and periods, about asking female patients about their periods, because amenorrhea is concerning in itself, and if it goes on for more than 6 to 12 months, we run into the risk of bone density loss. So I think for me, having that actually on a kind of a drop down on the consultation menu or in an investigations, depending what software package you use, is actually really helpful, Aidan Moore.
Great. You mentioned neurodiversity, and you highlight in your update the overlap or association between neurodivergence and disordered eating and eating disorders.
Yes, absolutely. I think, like all neurodivergence, we probably weren't very aware of this in the past. We're much more aware of neurodivergence and overlaps in mental health now. The GPU that we're talking about is an update from late in 2025. This section wasn't even in the previous version, which is the quick reference guide from 2020. So it's very much an emerging area of awareness for us around neurodivergence and eating disorders, and there's quite a lot of research happening in this area. The one that's probably most commonly known, perhaps, would be about the overlaps between autism spectrum disorder, or ASD, and eating disorders such as ARFID. ARFID is avoidant restricted food intake disorder. It's really a very intense type of food sensitivity, almost an extreme of picky eating. And there's quite a strong overlap between ARFID and autism spectrum disorder. There's also an overlap with ASD and anorexia nervosa. Then from the point of view of ADHD, we're seeing a lot more people identifying with ADHD in the last couple of years, and we're probably much more aware of it in general practice. So there can be different areas where ADHD overlaps with eating disorders. One example would be that somebody with ADHD who is on medication, so something like methylphenidate or lisdexamfetamine, that this medication can interfere with your appetite. It can reduce appetite. And for somebody with perhaps a history of eating disorder, there might be a risk there that they might actually not be eating properly on this medication. So it's just something to keep an eye out for. On the opposite side, somebody with ADHD can also be inclined to be a little bit hyperactive with their eating. So maybe a child might be obviously hyperactive jumping around the room, but an adult, you might have actually more increased things like snacking or impulsive eating, because maybe they can't watch a movie without eating as well. So they might be inclined to snack more. And that's an overlap really with ADHD impulsivity and issues with maybe executive dysfunction. So this might just be snacking, it might not be problematic, but I suppose where we would be concerned is where it could run into almost an overlap with binge eating disorder. So just to define it, what binge eating disorder is when somebody is eating a large number of calories, way more than their normal number of calories, in a specific time frame, and they feel out of control, that they're not in control of what they're eating. And importantly, the difference between that and bulimia is that there is no compensatory mechanism. There's no compensatory, say, vomiting or exercise. It's just the increase in calories. But it's really important that I guess all of us have moments, right, where we just eat a little bit too much. But it feels they're out of control. They feel a compulsive urge to eat that they don't feel in control of, and they feel a lot of guilt over. So it's when it moves from just maybe snacking, which is pretty harmless, but I suppose if it moves towards binge eating disorder, and now binge eating disorder obviously doesn't just happen in neurodivergence, that can happen anybody, and is probably a lot more common than we're aware. I just sort of came into it and when we were talking about it, but binge eating disorder is across the population. People probably don't come into their GP with it the way they should, in a way, in that they often feel it's their own fault, feel a lot of guilt, and that they're not controlling their eating, and sort of may not identify it as an eating disorder. And we may not, as doctors, identify it as an eating disorder.
That's really interesting, Aoife. You mentioned there about the prevalence of binge eating disorder amongst the population more broadly, and how patients may not ever come to the GP with an issue like that. And of course, people can struggle with some of these issues for years, can't they, before it comes to the attention of anybody? It's really when things get to quite a rock bottom, you might say, before they might present.
I think so. I think that probably we underestimate the prevalence of binge eating disorder. We don't have really good Irish statistics for it. Generally, it's not something that they see in the specialised clinics. They tend to be very much more focused on the anorexia and bulimia patients who require a lot of care. So I think this does fall under GP care a lot, and we possibly under-recognise it. And I'd say people in general under-recognise it. It's a spectrum, isn't it? It can go from, we all feel, Christmas chocolates after, watching a movie. That's not what we're talking about here. We're really talking about significant, large amounts of calories in a way that just feels sort of compulsive and out of control, and that the person possibly feels really guilty about. And it's this element of sort of almost self-flagellation that this is my fault. And I'm sure in time we can link this with, issues with the obesity epidemic and all the new medications there. And interestingly, one interesting point for me is that Tyvence, which is lisdexamfetamine, in other countries is licensed for binge eating disorder, not in Ireland, but for binge eating, and Tyvence, as we know, we use for ADHD. So there's overlaps there, which I think in the future will become interesting. We're just not quite there yet in Ireland.
And you mentioned that some of the specialised clinics, they don't really offer a service for binge eating disorder. Apart from Tyvence and other jurisdictions, are there any interventions with an evidence base that we can offer patients who present to us in primary care?
The evidence base, as such as we have it at the moment, is really around self-directed care, possibly, I suppose, identifying that this is an issue and looking at things like there's a book called Overcoming Binge Eating by Chris Fairburn, for example, that would be recommended, and we can pop that link in maybe. So it really is around kind of guided self-help at the moment. I'm not sure that this is enough for everybody, and I think there's maybe potential in this area for treatments to develop, but that's where we are at the moment.
Okay, very interesting. Thank you. So let's move on to examination. And I was heartened to find that it's straightforward, quick, but importantly, not just about BMI.
Absolutely. And again, I would say that it's useful to have this, maybe even just to be aware that it's a fairly straightforward examination, but again, just to allow yourself some time for this, because again, I found that the whole consultation goes by and I haven't even gotten to this part. So really, BMI, while I've already said it's not the be all and end all, it is very useful to measure and to have somebody's height and weight and their BMI calculated, because it gives you a baseline and we can record it really easily in our charts. For children, you would use the centile chart. It's used as a BMI centile rather than as an absolute. So there's little differences there in terms of age. So it's really checking height, weight, and a BMI calculation. A blood pressure check, ideally a few times, sitting and standing, because you might notice a drop when somebody stands up. Checking for heart rate, with bradycardia being the most common cardiac presentation. Temperature, you mightn't always think to check a temperature, but the body temperature can be reduced in somebody with anorexia. So height, weight, BMI, BP, heart rate, and temperature, all really vital signs that we check all the time. So really no different. And then the only thing that might just be a little unusual is checking the muscle strength. And this wouldn't necessarily be needed for every patient, but in somebody who you are worried about that they might have anorexia or they might have been vomiting a lot. And a low BMI, or there's areas of concern that you can check their muscle strength using the stand-up squat test and a sit-up test, and that is gone into detail on that on the GPU.
But as you say, in the GPU, that muscle weakness is considered a red flag.
Absolutely, yeah. So that can be useful. Knowing what the red flags are can be really helpful if we have somebody that we're worried about. I'm probably, being honest, talking about people with anorexia here rather than the other eating disorders. That's most commonly where it's a concern. And you're thinking, do I need to do a referral more urgently, that they can't wait on a waiting list for 3 months right now? And knowing which the red flags are, because if you do those blood tests and the examination and the muscle strength, and you are getting red flags, it makes the referral process much quicker, much more streamlined, because the emergency department have the red flags they're looking for, and it's much more likely that your referral will be successful.
And of course, like so many of these conditions, it's so important to rule out other potential causes for the weight loss. And you mentioned the investigations in the GPU, including checking for glucose, the TFTs, checking the celiac screen, even just an FPC, just to make sure we're not missing out on something else, that we capture everything. Again, the GPU goes into a very good summary. And again, having it on your desktop is a really quick way of just looking up what's needed. But you also talk a little bit about the role of the ECG, and even, although they're very young, in some cases, the DEXA.
Absolutely. So again, these investigations aren't anything too wild and wonderful. It's just kind of having an idea of what's needed. For me, in my practice, what I often find is bringing somebody in, probably back in for these tests, is usually what happens, unless it's an absolute emergency situation, because our bloods go out every day at 11 to the hospital from our practice. And if it's later in the day and you do blood tests, they're sitting overnight, and things like potassium, as we know, can be affected by that. And that's really important for these patients. So, one thing I would probably do is get them back in maybe the following morning to have their blood test done. The FBC, important both for, ruling out other conditions, but also somebody with anorexia particularly, you might notice a reduced white cell count because their bone marrow may not be functioning properly if they're very malnourished. Likewise, vitamins. Funnily enough, a lot of them are very good of our patients are good for taking vitamins. So sometimes the vitamins are quite good because they're supplementing. But obviously we do need to check, are they actually absorbing? So checking their B12, folate and ferritin and their celiac screen, just in case it's a malabsorption syndrome, so important. For ECG, a baseline ECG is really useful. They do look for it when you refer. So anybody that you're thinking I might need to do a referral here, a baseline ECG is a requirement anyway. But particularly if their BMI is under 15 or they've had rapid weight loss. And this is really about the prolonged QT interval risk. The DEXA scan, I know we don't tend to think about it in this age group, but if they've had amenorrhea, we already mentioned about that risk of amenorrhea. And if you've been underweight for more than a year, or you've had amenorrhea for more than 6 months, a DEXA scan is actually indicated. And unfortunately, I do have patients in their early 20s with osteopenia and osteoporosis due to eating disorders. So it is very real. Bone pain is another one for the DEXA scan. We'd have some patients who are quite into athletics, and as well as having a low BMI, or also exercising very heavily, and stress fractures are quite common. So bone pain would be another reason for getting a DEXA. It's important, one just point I'll mention there is one of the tests we'd recommend is the liver function tests. And they are, in somebody with anorexia again, I'm probably focusing on them, that raised LFTs are not uncommon. And it's important to recognize and to explain to the patient that this is basically in somebody who's really malnourished. The raised LFTs are due to liver autophagy, which basically means the liver are, almost eating itself. And that the cure for these raised LFTs isn't really liver ultrasounds and hepatitis screens, though you may need to do those things for other reasons. Of course, it does depend on the patient. But it's actually getting back to a normal diet and being properly nourished will actually improve the liver function tests.
Okay, so we've been through the history, we've been through the exam, we've done our investigations, and now we're on to referrals. Maybe we should start, Aoife, with the most serious. Who needs to go to the emergency department or the AMU?
So typically that's probably going to be our patients with anorexia and low BMI. And I know there are variations and we can't be absolute here, but typically that's what it is. So for our patients with very low BMI or anorexia, or who've had very rapid weight loss, they may need parallel referrals because this affects both their physical and their mental health, as we spoke about at the start. So where I'm living now, in Cork, we have an acute medical assessment unit, and I would probably refer there rather than to the regular emergency department. And in parallel, refer to our eating disorder services. Or maybe they're engaged already with the eating disorder services, but when you notice on a routine checkup that perhaps they've lost weight or you're worried about blood results, and they may need referral to both places. For those referrals, it is really useful if you have already checked what they're going to ask you, which will be around the blood pressure, the temperature, the blood results, because if you're identifying red flags in those areas, it will make the referral process simpler because you're really providing what they are looking for. And the Irish Emergency Department guidelines were only produced recently, I think was it in 24 or 25, and they follow the same guidelines which are based on the UK MEAD guidelines that are in the GPU. So I guess we're just all singing off the same hymn sheet here, that we're all looking for these parameters, and if somebody has really low BMI and their bloods are going off, or there's problems on the ECG, and you're worried, you're really worried about this young person, that you can refer to the emergency department or medical assessment unit in parallel, as well as referring to the psychiatry, local community mental health, or the special, ideally if you have it in your area, the specialised eating disorder teams. So it would be both. And I think it can be quite hard to remember exactly all of the blood tests and the results and so on. So that's where it's handy to be able to, maybe if you look at the medical risk assessment in the GPU, and there are links to the Irish Emergency Department guidelines and the medical emergencies and eating disorders or MEAD guidelines. So that can be really helpful, because it's really hard to keep those in your mind. You probably just need to go and check them.
Indeed, but as you know, just to emphasize the point, I find it often very useful if I'm worried about somebody, whether it's being referred on to an urgent outpatient appointment or indeed to the ED. If I can point to a national guideline, it can be useful just to say this referral is in line with the guidelines that you guys produced.
Yeah, and we've great care in the AMAU here in Cork, and these guidelines have really helped us to develop kind of a shared care, even though I know we don't have any resourcing for shared care for eating disorders in general practice. Unfortunately, this isn't resourced work. But at the same time, when you have somebody with, a very low BMI in front of you and you're genuinely really worried, knowing that you have a team working in the AMAU who will be singing off the same hymn sheet, looking out for the same things you are, and are willing to work with you, is just so helpful. And I think it is really useful to be aware of the guidelines, and it really does help with referral. For example, I had a patient not that long ago, and the lab rang me on a Friday afternoon, because it's always a Friday afternoon, and her glucose was it 1.6? I don't know how she was still walking around, and I rang her, and when the lab rang me, I rang her, and she was on a train platform in Kent Station in Cork, about to head off home for the weekend, and I had to talk her off the train and back into Cork University Hospital, where they saw her in the AMAU that night or that evening, because we were so worried about this extremely low blood glucose that I'd taken the test that morning. So it just showed how, when we were all working together, it really did work for this patient. I think one thing that will be helpful there, I'm hoping, is that we're in the process of developing an EU referral for eating disorder specialist services, which will help maybe with that communication as well. That will be a specialised e-referral.
And we don't necessarily have the e-referral piece completed just yet, but we do have the evolving rollout of the services. So could you maybe tell me a little bit more about this development in the community around these specialist teams to manage people with eating disorders? Because I suppose it is one of those areas where, up until quite recently, it was easy to get that sinking feeling and know somebody needs help, but then be at a loss to find the appropriate services in an appropriate time frame.
Absolutely. And as I mentioned earlier, living in Cork, I totally, for most of my career, there has not been a specialised eating disorder service for adults where I'm working. So I very much agree with you there. And the eating disorder specialised services are basically being developed through the country and rolled out. And this is going back to the National Clinical Programme model of care back in, I think it was 2017, when they, I suppose identified that this is the service that was needed and started to open eating disorder specialised services for children under 18s and for adults over 18s. And this has slowly been happening, and it can be really frustrating when it's not in your area yet. But when they do, or when those services are opened up in your area, it is a game changer. So for us, that's only in the last year or two, and it's been massively helpful to have this service here in Cork. So we do have a link on the GPU to a page in the HSE website where there are names and contact details for the services that are open already around the country and those that are being in development. Now, we didn't put the list into the GPU because new services are opening and it would be hard to keep it up to date, but we do have a link to the HSE page where you can have a quick look and see what the services are in your area.
And while we're talking about services, Aoife, could we pivot ever so slightly around the kind of services that we can signpost our patients to? Because I notice it's not just websites, there's an app as well.
Absolutely, yeah. The HSE have developed an eating disorders app. The easiest place to find that is actually on Bodywise. So Bodywise is the Eating Disorder Association of Ireland. They don't provide treatment, but they are funded by the HSE to provide support and education. And that's probably the easiest place to find things like the link to the Eating Disorders app, which is free. Another support that I think is really helpful that Bodywise have developed is something called the PILAR program, PILAR, and that's a free family support package that is 4 weeks. So I think it's Thursday nights. This used to be, pre-COVID, this used to be in person. So the Harriet, who would have run them for Bodywise, used to travel around the country to GAA halls and so on and run 4 weeks of a PR program. During COVID, it went online, and that's actually been massively successful because it's much easier to run them. You can run them way more frequently and people can join in from anywhere in the country. And it gets really good feedback from families. So it's 4 sessions. I think it's every Thursday evening, as far as I know, where you to help, it's a psychological and support program to inform and upskill families and loved ones who are caring for somebody with an eating disorder, because eating disorders can cause a lot of distress, as you can imagine, amongst families. It's very hard for parents to watch somebody intentionally starving themselves and isolating themselves, and it can cause massive distress. And, stress around a table, every meal becomes a battleground. So for parents, I think, or I'm saying parents now, but any family members that are supporting somebody with an eating disorder, having a look at the Bodywise page and maybe checking out the PILAR program, I would definitely recommend. And it is free.
Fantastic. And getting back to ourselves then on things that we can do in primary care, you mentioned in the GPU the fact that fluoxetine is licensed for bulimia in over 18s, which people may not be aware of.
Yeah, and now it's not perfect, but it could be really useful, particularly if it's somebody who has bulimia, which is binging and purging, and maybe they might have some low mood or anxiety as well. That fluoxetine is actually licensed to treat this. So you'd start at 20 milligrams and you can titrate up as far as 60 milligrams. Now, it's not a standalone treatment. And, ideally you would be maybe something you could start while you're waiting for them perhaps to get into a CBT program. But it is useful as an adjunct for binge eating and for the associated depressive symptoms. Absolutely. So it's something you might not be aware of. Some other medications are licensed in other countries as well, such as actually one of the ADHD medications, interestingly, Tyvence, but that's not licensed in Ireland. So at the moment here, it's just the fluoxetine or Prozac.
Okay, and you mentioned that the fluoxetine can also, address some of the depressive symptoms, which brings me on to my next point from the GPU, which is around that importance, of course, of thinking about a potential coexisting underlying psychiatric illness such as depression or obsessive compulsive disorder.
So yeah, there's a much higher overall risk of mental health disorders for those with eating disorders. So, a lot of our patients will also have maybe some anxiety or depression, obsessive compulsive disorder symptoms, because there's a lot of overlap. The compulsion to vomit, the compulsion to overexercise, they're quite compulsive, or the obsession about body size and weight. You can see that there can be a lot of overlapping symptoms, and actually, interestingly, fluoxetine is helpful with OCD as well. Substance abuse disorder, and personality disorder. So all of those things, there can be overlaps, absolutely, and it's important to be aware of that and looking out for it. And we already mentioned the slightly increased risk as well, the significantly increased risk, should I say, of self-harm or suicidal ideation.
Okay, I think we've covered most of the points there, or given an overview of the GPU. Obviously, this is not designed to be an exhaustive replacement for the GPU by any manner or means, but it's been a really interesting conversation to get the opportunity to speak with somebody who takes such an interest in it. And I really do think it's something that's, unfortunately, a growth industry for our younger people. So, I feel like, having gone through the GPU and having had this opportunity to speak to you about it, that I'm a little bit more confident in how I'm going to manage patients going forward, and even maybe have a lower threshold in my own head for screening younger people. Are there any pearls that you'd like to share with me before we wrap up, Aoife?
I suppose, just because to pick up on something you said there, yes, I mean, it feels like there is definitively more. The research is there that since COVID, particularly, that the numbers of patients referred with eating disorders, admitted with eating disorders, has jumped. So it's not just our perception that there's more. I think it's measurably higher. Particularly the COVID lockdowns were very, very hard on people for lots of different reasons, but also people with eating disorders. So recognizing that eating disorders are unfortunately on the rise, that by the time a patient comes into you as a GP, they're probably quite far down their eating disorder or disordered eating journey. Use of that phrase, disordered eating, I think that's a useful one. Remembering that it's not just young teenage girls with anorexia, that it's bigger than that. That can be, and frequently is, men, rugby players, athletes, those just, going into the gym, and that's body dysmorphia. There can be women with normal or high BMIs. So it's, it says, not quite just the stereotypical young female with anorexia. It is much broader definition. So bearing that in mind. And I do think having that sort of visual in your mind as a GP of that idea of the logical part of the brain and the eating disorder part of the brain, the patient in front of you, helps you to understand that patient's thinking and maybe might ease up some of the frustrations. And then lastly, if you do think somebody's an eating disorder, you do, particularly anorexia, early referral is important, because we just don't have access to CBT for eating disorders otherwise. And that the evidence-based medicine is that CBTE is important in anorexia particularly. In binge eating disorder, there's more evidence there, all right, for starting with, self-help. And we mentioned some of those in the GPU, for example, the book Overcoming Binge Eating by Chris Fairborn. So there is evidence for self-help for binge eating disorder, for example, but for anorexia, really, it's early referral. So there is sort of nuance within, the definitions of eating disorder. And look, nobody can keep all of this in their head. So if you have the GPU and you can quickly look at the risk assessment for eating disorder, are the resources on those kind of handy, I love the jump to buttons on the GPU that brings you straight down to the part of the GPU. As you mentioned, it takes about 15 minutes to read through it all, and sure, nobody has that time in the middle of their day, but you can use that blue button to jump to the bit that you're looking for, and hopefully that should be helpful.
Many thanks to Dr. Aoife O'Sullivan for speaking to me today. And don't forget to check the show notes for chapter markers and links to resources. If you've any comments or feedback on today's show, or indeed suggestions for future episodes, please let us know. You can contact us by dropping us a line at podcast@icgp.ie. And that's it for today. Many thanks again for listening, and until next time, take care.